So I think we'll start, and today I have the pleasure of introducing Andrew Thrower, who is a GI radiologist from the Basingstoke team. And I think the topic is extremely important. As clinicians, we know that we really depend on accurate radiology to plan our treatment, to plan the surgery. And at the same time, we know that radiology in peritoneal disease is very challenging. This is one of the reasons why trying to make a better system for how we report radiology in our practice is one of the topics that is important in Working Group 1 in the European cost action. So I think this is hopefully going to be a starting point where we can improve this important part of our work and hopefully be able to report some progress in our reports in the future. So Andrew, thank you very much for giving this introduction and to radiology. And so please just proceed.
Thank you. Thank you very much for inviting me. I will try sharing my screen now and hopefully bring up my presentation. Share and start there. Okay, I'm just going to turn off my camera while I do this, if I can. I'm not quite sure if I can. Fine. So yeah, thank you for asking me to talk. So I'm going to talk about radiology of pseudomyxoma, present and future. The future is in some ways a little bit hopeful, but we will come to that towards the end. So what I'm going to discuss is the aims of imaging, why we image, what we're looking for. And I'm going to just talk you through how I assess a scan. I wasn't quite sure what the makeup of the audience would be today, so I'm assuming that you are mainly surgical. You may or may not have a lot of experience of looking at CT scans. But hopefully you'll learn something new from this, and then we'll talk about, at the end, I'll come to future work, things that I hope to proceed with and to make some progress on, and where you can help with that. So the aims of imaging, obviously diagnosis is the number one thing that we're considering here. So we want to make the diagnosis of pseudomyxoma first and foremost, and that's often done on imaging, although surprisingly, sometimes when it seems obvious, it isn't picked up. And that I'll come to the questions you can ask of your radiologist when you suspect it on a scan. We want to describe the volume of disease. How much is there? What's the distribution? We want to help to plan the surgery. So really we want to try, as a radiologist, I want to outline structures that you may need to resect. If there's need for chest drains, if the pleural spaces are involved, for instance, and if the patient might need ITU afterwards for a particular reason, and also about resectability. Do I think you'll be able to resect it all? And if not, what might be left behind? And how might you counsel the patient in terms of, your likelihood of doing a complete tumour resection versus a major tumour debulking? And also, of course, we assess for recurrence with imaging. So everyone's familiar with the PCI. This isn't something we use in pseudomyxoma reporting in Basingstoke. I don't know whether other centres do. It's not something that we find helpful in the preoperative patient, because even a very high PCI PMP may be resectable in a specialist centre. So it doesn't help to describe resectability. We obviously describe volumes, but a lot of the volume may just be bland mucin, and therefore it's not particularly helpful. And it's more important to describe whether critical structures are involved. So what modalities do we use? Well, in our practice, we use mainly CT. It's the mainstay of imaging, really, in pseudomyxoma. It's often used in the acute presentation, and that's when the diagnosis is first made. It's very good for follow-up as well, and we use that primarily. Positive oral contrast is really helpful, I would say essential when we're looking at mucinous disease, and obviously IV contrast as well. So in terms of the protocol, we do a CT in a low-grade patient, abdomen and pelvis, with oral and IV contrast. High-grade patients, we would include the chest as well. MRI, we don't tend to use so much. We tend to use it in younger patients who may have a very long follow-up period. So if you've got a 25-year-old with PMP, then you may be scanning them for a long time. That's a lot of radiation, so MRI may be preferable in that sort of patient. It may be more sensitive for low volume disease, and you can see smaller amounts of fluid than you can on the CT, but that may or may not be useful. Sometimes our team don't really like to know about the very small things because they may not be able to do anything about it anyway, and actually it's not particularly of significance at that point in time. So it may be even a bit too sensitive in some patients, you might argue. It's very patient dependent. Some patients are very good with MR, some aren't. In terms of protocol, we don't use oral mannitol, which we would do for instance, colorectal peritoneal metastases, because it may complicate interpretation. You may have similar signal between the mannitol in the bowel and mucin outside the bowel. Now, there are other things you can use. For instance, pineapple juice, I know, is used in some centres. It's not something we've managed to do yet. We were planning to, and then look at it, and then COVID hit, so everything was on hold from that perspective. The other issue with MRI, we don't tend to use contrast for a straightforward low-grade pseudomyxoma follow-up, and we also use MRI as well as younger patients in problem solving. So if there's a particular question on CT, we may well use MRI to answer that question. PET-CT, we've never used in Basingstoke for pseudomyxoma. I'll come on to PET-CT again at the end. I don't know if other centres use it. Sometimes places will send us a PET-CT scan when they refer, but it's really of very limited use. So how do I do it? Well, firstly, the question is there ascites or mucin? So that's the mainstay of pseudomyxoma. That's what we're looking for, and it's obviously larger volumes are easy to see. It may not always be easy to tell why the ascites is there, but you know it's there. Smaller volumes can be hard to spot, and this is in the subphrenic space, and the area. Let me just see if I can stick a pointer on here. And really the area to look around obviously is around the edge, and you should see that the liver and spleen, and here obviously we've got the liver abut the diaphragm. The area is not quite in the right place there, but abut without anything seen in between. When you get something between, you get a little bit of low volume, low attenuation between the diaphragm and the liver. That's what we're looking for. Coronal images are really helpful to look for that. So here we've got a coronal image, and we can see right up on the liver dome. And I'd encourage you, if you're looking at scans, to look at the coronal images, in particular looking in the subphrenic spaces. It's very good. Here you can see on this slide where we've got the this low attenuation rim around it. That's just a small amount of fluid, which is actually surprisingly easy to miss, and radiologists are not always very good at seeing these, particularly because sometimes you can get diaphragmatic crura coming across, which may look like there's a bit of scalloping. You may get a bit of diaphragmatic thickening, but really we're looking for this sort of pattern up here. Paracolic gutters are obviously a common place to see disease, and in the paracollic gutters, really, you can see in this patient here that's got some fat. You can see where the peritoneum is here. You won't always see that, but you can here. And anything that makes it more visible than a sort of a tiny little hairline density is concerning. And here we've got some disease here. Now this looks like it's a bit lobulated here and here. It doesn't look typical for ascites, and certainly in the right iliac fossa here you can see that really does look like lobulated mucinous disease rather than just a little bit of ascites. So having thought, yeah, I can see, I'm suspicious it's Pseudomyxoma Peritonei. There's some ascites. I may think there's mucin. Next thing is to look for the appendix, and this is always the place I go to next. And the appendix, is it visible? Well, it's always helpful if it's calcified. You can see here we've got oral contrast on board, and we've got this rim calcified structure within the ascites. It normally tends to have a slightly different attenuation to the ascites, and you can see here that it's slightly lower attenuation. On this side here, we can see we've also got an appendix here, and that's outlined by fat, also with some calcification. It is quite common, as I'm sure you're aware, for it to be calcified. However, it's not always calcified, and it's not always easy to see. It may be surrounded by mucin, and this is quite a low dose scan, and one of the issues that you can have with a large volume of ascites, it can be quite noisy. This is quite a noisy scan, and there is an appendix here, and there's a fleck of calcification which helps us. Without that, it's very difficult to see, but often I will look for the cecum, look for something coming from it, look for any funny bits of fat, try changing the windows to see whether that makes things a little bit obvious. Again, here you can see slightly different attenuation to the fluid or mucin around it, and this is an appendix tumor at the tip of the appendix. Here's the cecum here, and there was on the CT you could actually follow the appendix through to this. So you do need to look really hard for that. And one of the mistakes we often see people have made is they've seen ovarian masses, think it's ovarian cancer, and then the gynecologist has operated and found the appendix, which was there on the CT scan, but I think people haven't noticed it. It may be very hard to see. So always ask the question about the appendix. MRI can be really helpful here. Here we've got a Krukenberg tumor with an appendix adjacent to it. It's actually quite hard to see on the CT scan. It's a lot easier to see as a discrete structure on the MRI scan you can see there. So the next question I tend to ask myself is, are there Krukenberg tumors? We know they're very common and they can hide. If there's little or no ascites, it's very straightforward, as here. If it's large volume ascites, it can be difficult. And the reason that I want to let the surgeons know if there's Krukenberg tumors, thinking about often they rapidly increase in size. So it may be mean that the patient needs operating on sooner. It can also affect knowing that it's there preoperatively may then affect the surgery and what they're prepared for. You can see here we've got large volume ascites, but we've also got this enhancement within it, and often with it Krukenbergs you do get a bit of enhancement. I tend to follow the gonadal vessels down to see where they go, and often they will come to sort of an area of more diffuse enhancement like this, which is a septation or something within that ovary. So there's always a chance of seeing a Krukenberg, although it may be invisible within the ascites and may only be seen on MRI easily. Next place I tend to look is the omentum. Now, mental infiltration has a spectrum of findings. It can range from the very subtle. So here we've got the omentum, this fatty layer beneath the abdominal wall here, and you can see we've got some very subtle stranding. This is a little bit more focal, but it is quite difficult to see, and it may be more subtle than that. That ranges then to this sort of lobulated appearance, in this case at the bottom, through to frank omental cake here. And sometimes the only clue you get that there's an omental cake there is these little bits of residual fat in the omentum that you can see. The attenuation is often slightly different, and again, changing the windows can be helpful. But that's sort of what we often see, and that's that sort of dense cake that is really quite rigid. So having sort of looked around the place a bit, and I thought, yes, there's an appendix tumour, there's crook and bow tumours, there's a mental cake. The next thing I want to think about is, are structures involved? And I think this is where it starts getting quite difficult, because there's a difference between mucinous ascites, which we're seeing here, and where you get mucinous deposits where the structures are actually involved. This is a case with some enhancement here. This is an adenocarcinoma, so this is peritoneal disease with ascites. And you can see we've got a nice smooth liver margin there without any scalloping. Of course, with mucinous deposits, we see the classical scalloping of Pseudomyxoma peritonei, which we have here around the liver. You can't appreciate it on the spleen, but clearly here, this doesn't look like ascites on the spleen. It's a sort of slightly lobulated. There's not large volume fluid around it compared to what we see up here. If this was adjacent to the spleen, we'd be happy to call that ascites. But this clearly looks like this is lobulated disease on the surface of the spleen and on the liver there. Excuse me a moment. And then MRI scan shows that differently again. So here we've got, this is what we're seeing on the surface of the liver, these locules of mucin growing into the capsule of the liver there. And you can see we've got large volume disease here in the lesser omentum and in the portal structures. Also lobulated bits around the margin here. And here we've got just a large volume mucinous ascites. This often looks quite simple, but you do actually have some septations within it. And I suspect if I put an ultrasound probe on that, it would be a lot more complex than I can appreciate it on this. You sometimes see that sort of density as well, where you get some ascites, or and then outlining that on the peritoneal surfaces, you see this sort of density like this, which is where we've got that mucinous disease on the surface. It may be calcified. It's always helpful when it's calcified. Number one, you know it's not ascites. Number two, it shows itself a bit more easily sometimes. And here we've got large volume calcified disease around the liver, in the porta, and around the stomach there. So having thought about what structures may be involved or not, or what denotes involvement, and really I'm looking for sort of mass effect on those things, as I've shown you with the scalloping and so on. Then think about, okay, so what disease is going to limit the resection now? And there's three areas that we tend to look at mainly. We think about the stomach, we think about the porta, and we look at the small bowel. These are all things that if the small bowel is wholly involved, then you're not going to be able to resect the whole small bowel, for instance. With the stomach, you often get some involvement of the gastric antrum, and you may get this sort of annular disease around the gastric antrum. Here you can see it. This is obviously a mass effect scalloping upon the liver here. We've got a similar appearance on the stomach, and we've got some food debris in the stomach here. And a patient like this may need a partial gastrectomy, so it's important to try and flag that up. The patient may have symptoms of gastric outflow obstruction, or they may not. If it's more extensive encasement, then it may be unresectable, and this patient was deemed to be unresectable. They've got disease all around the stomach here, and as you come down, you can see that it's really quite encased. And in this case, as told, the left gastric vessels were involved, and the patient would have needed a total gastrectomy, which wasn't something that was thought to be possible in this patient. I'm not sure whether they've ever done total gastrectomies in Basingstoke. I'm not aware of coming across a patient, but certainly partial gastrectomies are not uncommon to do. Portal structures are obviously important. Portal vein involvement, you can see we've got some mass effect upon the portal vein here, and that's you can get really quite marked compression of the structures there. The French group have published this paper looking at infiltration of the hepatoduodenal ligament. And here we've got a little bit of fat in the hepatoduodenal ligament, which we can see, as opposed to here, where the hepatoduodenal ligament is effaced, it's infiltrated, and this would be deemed to be resectable, whereas this would be deemed to be probably unresectable. So we'll come back to the porter in a bit more detail in a couple of minutes. The small bowel and mesentery are really important and actually can cause quite a lot of difficulty. So extensive involvement is often straightforward. So here we've got oral contrast. You can see why we want oral contrast, because without it, you can see very little of what's happening in great detail. You suspect that's involved, but you really want the oral contrast on board to see that. And we've got this sort of scalloping effect here on the small bowel that you can see, and that's clearly involved. We've got some dilatation, so I'm looking for this caliber change. I'm looking for dilatation, suggesting that there's some hold up as well. And you can see here on the coronal image this area of dilatation, and this comes into an area of marked small bowel narrowing there, and there's also a loop coming into that which is also narrowed. Other loops contain some gas and don't look so bad, but you can see we have significant gastric involvement here as well as the scalloping of the liver we discussed. So looking for indentation, I'm looking for changing caliber, and I'm also trying to describe the extent of involvement. Is it limited? Is it multifocal? Typically, you see it more in the ileum, in the right islet fossa than jejunum, but you may well get extensive jejunal involvement as well. Here we've got some small bowel normal. It looks normal caliber, but obviously this loop here is involved there as well. And the mesentery looks reasonably clear. Again, oral contrast, it will come, it's a drum I keep on banging. Mucinous masses in the mesentery are also seen, and if you don't give oral contrast, I can't tell you what's going on in here. We've got some fluid attenuation, we've got some gas. It doesn't look very happy bowel, that particularly, but I can't tell anything. Once you give oral contrast, and this is the same patient, similar time, one with this next one with oral contrast at the same level, and you can see we've clearly got mucinous masses that are very, very difficult to see without the oral prep. And this would then enable me to have that conversation with the surgeons, describing where these are and what effect they're having on the bowel. Mucinous ascites is common, and you often get little bits of mucin or ascites within the mesentery. It tends to be quite smooth. You tend to be able to follow it, but what I'm worried about in the mesentery is when it becomes more nodular and more discrete, a bit like we saw on the surface of the spleen earlier on that earlier slide. You may also see enhancing tumour with high-grade disease, which may be involving the mesentery or serosa. And just to demonstrate the difference between CT and MRI here, the CT scan without oral contrast, the small bowel doesn't look particularly happy. It looks a little bit irregular, a little bit ill-defined, but there's quite a lot of noise on here. It's not easy to see. You don't really appreciate what's happening in the colon here so much either. I think that may be the appendix tumour there, I can't quite recall. But then at the same level, we've got this MRI scan, and there's quite marked thickening and enhancement over the small bowel, which we just do not appreciate on the CT scan. And again, over the colon here, you just really don't see most of that, even changing windows and so on. So certainly MR can be useful. The other thing to say about this case is that the small bowel looks tethered. It looks like the mesentery is sort of tethered in here. It doesn't look like this sort of free floating bowel. Which is something that we also look for. And the same patient on a T2 waist imaging, these are not great images because of the distension of the patient caused quite a lot of artifact here, but you can again see that we've got this marked thickening of mucinous disease over the small bowel, over the colon. This is the sigmoid colon here, which is really quite grossly involved there. So coming back to the Porter, a CT scoring for resectability has been published in 2018, looking at the perihepatic region and measuring 5 distances. So between the IVC and portal vein, in the falciform ligament, in the lesser omentum, between the caudate and left hepatic lobe, so in the fissure for ligamentum venosum, and between the caudate and right diaphragmatic crust. And this is from the paper measuring these different measurements here that you can see. And the idea is to add those together and calculate a sum score. And for unresectable patients, the median score was 46.2. That's the IQR there. And for resectable patients was 0 with an IQR 0 to 14. And it was said that less than 28 millimeters was the optimal cutoff for resectable disease. This is something that we don't tend to use generally in our practice. I think it's something that we haven't looked at ourselves. I think it's some work we probably do need to do to see whether this is true in our patients as well. So that's really the assessment of the disease, how I do it. I think that's sort of the major things I haven't really discussed in the pelvis, for instance, looking at the rectal involvement and so on. But generally speaking, we also discuss the pelvic cul-de-sac, but there aren't any particular, other than the ovaries, any particular things that would stop resection. It may be that the patient needs an anterior resection for pelvic disease there. Just think about post-op imaging now, and a few hints for that. The one thing I've learned in my 11 years of doing this is not to call recurrence too early. Acellular mucin may resorb slowly over years, and this is a patient, this was their pre-op, and I think they had this externally. They had an appendix tumor and some fluid was seen on the scan. On the post-op imaging, there was still some fluid there, and they had then several other scans. We were just observing it, and that over the course of a couple of years actually completely resolved, but it did take a long time to go. And calling recurrence here obviously would be too early, and it would cause concern for the patient, and also raise the possibility of further surgery, which wouldn't be needed in this case. However, recurrence does occur, as we know. How do we know it's recurrence? Well, it often has a different distribution to the primary in my experience, or it has a different appearance. So you may get liver scalloping where there wasn't any pre-op. You may get small bowel involvement where there wasn't any pre-op. Abdominal wall is often involved, and also you get disease in the pleura as well. I think if I see just a little bit of ascites post-op, I play it down. If I see lobulated disease quite extensive, particularly throughout the mesentery, I tend to call it suspicious, and we may need a further early scan to follow up on that. But I try not to label it as recurrence too early, because I have been caught out before, and I don't think that's helpful. Examples of abdominal wall recurrence: you tend to see it at drainal port sites, around the stoma where it works its way through, and also the base of the laparotomy wound is here. And this is the sort of disease where you may get fistulation from the small bowel into this. You may see bubbles of gas within this, and then it may then fistulate through the abdominal wall. We've seen that quite a number of times. And again, oral contrast really helpful to show any fistulation in the follow-up. Pleural disease, always be aware of that. You may get reasonable volume disease like this. You may just see a few small nodules along the fissures, for instance, but it is worth just casting an eye on the lung bases carefully to have a look for that. How do we know who's going to recur? Well, I think we've got various things that we know. We know high-grade disease. We know tumor marker positive disease. This was out of Japan, this paper. they were looking at patients with CC0 or CC1 resection, and they found that the presence of scalloping of the liver was an independent predictor of significantly shorter disease-free survival, so earlier recurrence. And the greater mucin deposition, so if it's more than 20 millimeters, that was significantly associated with shorter disease-free survival. I'm not sure that this is particularly our experience. One note was they did a digital glistenectomy rather than diathermy. I know in Basingstoke they used diathermy on the liver capsule. I don't know whether that might affect it or not. Again, I think this is something that we would be very interesting to look at in our cohort of patients and see whether this is something that we've seen. It's not something that I particularly recognise, although it may be that the scalloping of the liver has the biology of the disease is slightly different from if you don't have that scalloping. And again, the same group of published this PET-CT prediction of recurrence, and the short answer to this was that the high-grade disease showed FDG uptake, and these patients showed more recurrence, which is exactly what I would expect. Low-grade disease doesn't tend to show FDG uptake, and these patients would tend to recur less than the high grade. So I'm not sure that this particularly is helpful. I think other markers, the high-grade disease, the tumour markers are just as useful. And that leads me on to the future. And EuroPMP, the radiology arm. So I've been involved in this, and I haven't sort of managed to progress much at the moment, but I would like to. There are things that we're thinking about in terms of do we need imaging standards? Do we need standard protocols and techniques which would guide the pre-op decision making? Do we need to standardize terminology? So I find myself sometimes struggling to describe what I'm seeing in terms of involvement, in terms of mucin, in terms of ascites, and so on. So I don't know whether standardized terminology would be helpful. Standard post-op follow-up may be helpful, and also it's been suggested that some sort of a minimum imaging data set for trials may be helpful, just so we can compare things, or when you see the studies that we've looked at, that we know that we're talking about the same thing, if we're talking about disease, if we're talking about involvement, and so on. I've been trying to reach out to some radiologists, and I haven't really got very far at the moment. I think we need radiologists from a large radiologists that have quite a significant throughput in their centre. I don't know what that significant throughput is number-wise. Obviously, in the UK, we're somewhat atypical to the rest of Europe, and so it's a plea really for, what do you want from the radiology arm of this? What do you need to know? What do you think we should be looking at? And also, do you have any radiologists that would be interested in linking up and looking at these things? There's not a lot of literature out there on some of this stuff, and so a lot of it's mixed up with colorectal, peritoneal metastases, gastric, ovarian, and so on. So pseudomyxoma on its own doesn't really feature that much that I can find in the literature. But if you have any thoughts, then let me know. And that, I think, brings us to an end. So in conclusion, really, I've discussed that imaging PCI is not really a guide to resectability. It's not something we tend to use, but we do try to assess the critical structures, the stomach, the periportal structures, in particular the small bowel. I'm not sure if scoring systems are useful. I think there's work to be done here. We've had a couple of things published, and I think there's something to look at there, and maybe to work on, and also then it comes down to the EuroPMP and the project associated with that. So I'd like to thank you all for listening, and I'd be very happy to answer any questions. I've just got to work out how to stop sharing my screen. There we are.
Okay. Thank you very much, Andrew. I think this was a really great talk, and I think you covered the most important aspects of this challenge, really. I would just like, before we start with questions, I would just like to emphasize your final remarks regarding inviting radiologists all over Europe to join EuroPMP. If you contact Dawn, she will help get you linked up to the EuroPMP cost action, and then you will be on the mailing lists so that we can keep you in touch with Andrew and with Andreas, who's working group 1 leader. So that would be really great, and we really need more radiologists to join. We have had some questions from in the chat, and I'll just mention from Mark Pocard. Is it possible to separate low grade from high grade on the first image before any surgery? He asks.
Sometimes I try to sometimes. Fahiz isn't here to tell you how successful or otherwise I am. I think there's features that make me more suspicious for high grade. So if I see that there's quite a thick rind of tissue and enhancement, then that certainly makes me more suspicious. And if the small bowel is involved sort of straight off, that also makes me quite suspicious as well. But I've not come up with any really good system. Now, this is again something that thankfully we've been down on colleagues lately, and we've got new colleagues who've just started. So I'm hoping that this is something that is in the pipeline that we want to look at all of our PMP patients and try and answer that sort of question, in fact, which I don't at the moment have any optimal answers. But I think on the first imaging, there are certainly things that make me concerning.
Okay, and then there is a question from Joanna from Greece, I suppose. Is calcification of the appendix wall associated with more high-grade histology or adenocarcinoma?
I think that's probably a question for the oncologists, not the oncologists, sorry, the pathologists. In my experience, no, I don't think so. I think we see quite a lot of calcification in low-grade tumours. And so I think if I see calcification, that doesn't make me think, one, that it's high-grade or low-grade, to be honest. I'm not sure if there's any pathologists here. So certainly a question I can ask Norman. It's not one I've asked him before, but my experience is that I don't think it affects it.
I think I agree. I haven't really seen that. I think actually it's quite common in low-grade disease. If anyone else has a question, please feel free to ask Andrew directly.
I can see that Max, presumably Max Lahey is online. Hi, Max. Yes, I will contact you about it. Thanks.
Okay, any more questions?
Can I ask a question to the people that are here in terms of are you doing anything different to us in terms of staging things? Are you using MR more or do you rely on CT? Any thoughts from your experience? And also, is there any question that you think we need to look at in the radiology community to help you? What are we not telling you that you need to know?
So I can start off. So in Oslo, the main modality is CT, and I'm going to again discuss the question of positive contrast, because our radiologists don't like it.
Really?
So it's, but I can really see. So I will regretfully, I was unable to have our radiologist join this session, but this will be available as a recorded presentation. So I will absolutely have them take a look at the images that you showed in your presentation, Andrew, because I think they're very instructive regarding this question. Yeah. So this is, yeah.
I think I showed some deliberately showed some quite extreme images, but even in the less extreme images, cases, I find it really, really helpful, I have to say.
Yeah, and of course, the small bowel involvement is extremely critical in PMP when it gets to resectability. So if there is any improvement to be gained from that, I think this is very valuable. So we will discuss again.
I was just saying in the chat, actually, Max is saying using CT MRI as a problem solver. Other people saying something obvious in PET-CT work associated with high tumor burden and worse prognosis. I think that's what we've seen. I think there's probably other markers that tell you that. The question is whether it's important to know that preoperatively in terms of that. In Paris, more MRI. PET-CT in Lyon. I might have to get in contact with Pascal to ask about that in Lyon. And Angela, oh hello Angela, has her scans in Basingstoke. I probably report a lot of your scans then, and she has her scans with us, and I think has a poor experience of receiving oral contrast locally, and I think that's true. Radiology generally is going away from oral contrast. It's expensive. It is patients have to be in the department for longer and so on. But we do maintain it certainly for this. So.
I think also that some of the MRI images that you show are instructive, that there is something to be gained from MRI. But will these protocols be very, I mean, do they take a lot of time? What's the time frame for getting decent images?
For the MRI, it is not. So if we're doing the full lot which we're doing colorectal peritoneal metastases, it's probably about a 45-minute scan. For pseudomyxoma, we tend to curtail it to a lot of the T2 weighted imaging, which tends to be quite quick. So you can be on and off in half an hour. So it's a sort of fairly standard length scan. If that, I mean, you could probably do one much quicker and get the majority of the information you need actually with just a few sequences if you wanted to.
Okay. Good. Okay. So any more questions or feedback?
So I think I can see in the chat that Max has asked if there's a need for a different staging model other than PCI in pseudomyxoma. And I think that's a very good question, and there may be something that we need a different staging model and scoring system, and maybe it's a mix of the things that I have presented today, and maybe that's a starting point to think about. It's certainly something I think that we as a group could look at.
And I see Mark is asking how about SPECT CT. I don't.
Yeah, we haven't used that here at all. We just stick to standard CT scan and MR for this. We don't use any SPECT CT at all for this.
So Mark, do you have any experience with that in Paris? Since you're asking the question.
Bit disappointed. Yeah.
Yeah. Okay. Okay.
Is there anything helpful in the origin of PMP and radiology site? I'm not quite sure what that question means.
Perhaps deciding on the origin if it's not appendix sometimes.
Oh right, okay, ovarian or appendix or appendix. Yeah, so I mean, if I can't see an appendix, then obviously we look elsewhere. We've had a number of cases of true PMP arising from appendix tumors within ovarian, within teratomas. Actually, we don't deal with ovarian cancer in our team. We've seen urachal tumors causing something similar. I think we may have had a pancreatic, and you do occasionally see ovarian tumors with it, but I don't have a huge experience of those, to be honest.
Okay. So if we have no more questions in the chat, or yeah, then there is final word from Dawn to please contact her, and this is from this presentation particularly to any radiologists who have attended the talk. Please let us know who you are and let us sign you up so that we can keep you connected and with the other radiologists in the action. That would be really, really great. So okay, but I think we will then say thank you to Andrew for sharing this great talk and your experience with us all, and we're looking forward to the next session in this lunchtime, late lunchtime, I would say, talks. So have a nice weekend, everyone, and again, thank you, Andrew.
Thank you very much for asking me.